Our next presenter is Michael Chua, who is from the New York Eye and Ear Infirmary, Mount Sinai, and he's going to talk about a choroidal mass lesion.
Hello, I'm Michael Chua. I'm a second-year resident at the New York Eye and Ear Infirmary of Mount Sinai. Yeah, I'll be presenting this case of a choroidal mass lesion. This is a 63-year-old female who was referred to the ocular oncology clinic for a growing choroidal lesion in her right eye over the last 5 months. She denied any visual complaints, and her review of systems was negative. She did grow up in Georgia, and she worked as a baker. She had denied any recent travel. She did not have any past ocular history. Her medical history was notable for asthma, hyperlipidemia, hypothyroidism. She's had 4 C-sections in the past, an appendectomy, and a right hip replacement. And she was on aspirin, Synthroid, and various inhalers for her asthma. On exam, her vision was 20/25 in both eyes, and her anterior segment exam was normal. Pressure was 20 in both eyes, and her anterior chambers were deep and quiet. Her fundus exam in the right eye, though, was notable for 1+ vitreous cell with no significant haze, and this large, elevated, creamy-colored lesion superior to the disc with overlying retinal vessels and some patches of hyperpigmentation that you can see there. Left eye fundus exam was normal. B-scan through that lesion of the right eye revealed thickness of 3.9 millimeters with low to medium internal reflectivity. B-scan through the left eye was normal. OCT through the fovea of the right eye showed normal retinal architecture, but it did show some hyperreflectivities in the vitreous, likely representing that cell that we saw on exam. Retina's flat.
Can you go back to the OCT again of the lesion?
The OCT, you said?
Ultrasound?
Yeah. The ultrasound.
Oh, ultrasound.
Yeah, that's the one. So no shadowing. The sclera looks like it's intact.
Mm-hmm. No shattering.
It looks like the choroid retina, everything's elevated above it. The image on the right looks like it's got a little bit of a bow to it.
Mm-hmm. What to it?
Bow. It looks like it's indented. It looks like it's excavating the choroidal tissue. And it's hard to differentiate that from the sclera at that particular location.
So did they think that this was in the retina or the retina and choroid?
Yeah, that's what I was asking.
Thought to be choroidal.
Choroidal.
Yeah, it's your color picture. Go back to your color picture. You know, you got cells in the vitreous. If you're choroidal, it's definitely got retinal involvement.
Mm-hmm.
It can't be purely choroidal. That's why I wanted to see that before you went to the OCT. And up on the top, yeah, the supratemporal arcade there looks like there's some involvement as well.
Mm-hmm.
So it looks like if it's choroidal, it's pushing up into the retina.
Mm-hmm.
If it's retina, it's invading down. And it's a 4-month history, is that correct?
Mm-hmm. 5-6 months.
5-6 months, and it has not changed.
It was growing. It was growing. She was followed outside hospital.
And it's a single lesion.
Correct.
So we're talking, and by that time she's been worked up for metastatic disease, and there's no metastasis, I assume.
Yeah, you'll see.
Primary.
Yep. You'll see.
I'll see. Okay.
Basil, any comments on the appearance of the lesion?
I kind of agree with the previous comments. You can see the vessels overriding, so obviously it's a deep lesion. Just temporal to the lesion, I'm not sure if that's some exudates there that are subretinal, so whether or not there's an actual exudative response from this lesion would be interesting. I'm definitely interested in seeing the OCT over the lesion, or at least at the border of it, so you can clearly define the depth of it. But I also agree with the ultrasound that there was some choroidal excavation, and then I believe the ultrasound picture on the right showed a couple of areas that were a little bit more hollow on that lesion, or it almost looked like there might be intralesional cavities. So I'm just kind of interested in seeing what the OCT shows a little bit more.
Mm-hmm. There is an OCT through the lesion there, showing the elevation of the lesion. OCT through the left eye was normal.
Boy, you're skipping that OCT real quick. I mean, out of due respect. I'm a little bit lost here, because
not a good OCT. You need a Heidelberg.
I'm not sure what that OCT is. It looks like an enhanced depth imaging EDI that's got a flipped lesion because it's got this point up there. I'm not sure we can say very much about that
It's
OCT.
service that is unable to, I think, assess it completely.
Yeah.
Heidelberg would be better for this.
Yeah,
That looks like an artifact to me, Sandy.
Yeah,
Yeah.
that's what I'm trying to say. You can't interpret this
No.
image.
But what is the red line on there?
It's a false interpretation. That's the algorithms.
Okay.
just off.
Yeah.
With lesions like this that are so elevated, it can be a real challenge to get a good OCT. So sometimes catching various points on the lesion just at the border in a slightly different location might be a little bit easier to identify.
Or swept source.
Yeah.
So she did receive extensive workup. PET scan showed thyroid hypermetabolism, what was otherwise within normal limits. She had a mild leukocytosis, 12.15, with no eosinophilia. Her ACE was normal. Her toxocara IgG antibody was negative. She had a positive toxoplasma IgG antibody and a negative IgM antibody. Her quantiferon and FTA were negative. So given the suspicious appearance of the lesion, the decision was made to perform a vitrectomy with a biopsy using a vitrector.
So let's discuss the differential first, right? So I think, could this be a tumor? It could be, first of all, I still think this is in the retina, maybe from what I've seen so far. It looks like it's in the retina. So could it be an astrocytoma of some sort, or a rarer tumor? And then the second thing is a granulomatous process. There's not much inflammation seen, but you have to think of TB and sarcoid and things of that sort.
Right. I think, well, whatever it is, it'll be likely an atypical version of it. But an astrocytoma wouldn't quite look this way. Sometimes it can have intralesional cavities, and sometimes it can have some hyperreflective areas that you'll see a little bit of shadowing. And so I'm not sure it completely fits with that. It could be kind of an atypical amelanotic melanoma. That's not the field normally, but with the choroidal excavation, I think that's something that's possible. Something that's growing for 5 months with a negative systemic workup will be much less likely to be metastasis. So I think inflammatory lesions are also something to keep in mind.
Yeah, fluorescein angiogram, while you don't need to do one on these cases, a fluorescein angiogram might show you its internal vascularity, which would push you in one direction, or might show you a diffuse hyperfluorescence with what Lee was asking, but I think the biopsy, a fine needle biopsy, would be fine as well. I don't know if you necessarily need to do a full vitrectomy.
So the other thing is a retinoblastoma. So every once in a while we see really weird retinoblastomas in adults. So could that be in the differential?
So that could definitely be possible. Obviously, the patient is in their 60s, but that doesn't mean that it wouldn't necessarily be retinoblastoma. Sometimes you'll see the vessels a little bit more dilated in that situation and then kind of clearly diving into the lesion. I don't think the vessels were particularly dilated, but it is definitely a thought to keep in mind.
Was the chest CT negative?
Yeah.
Okay. And the ACE was normal, though it's in the upper limit of normal.
Right.
Was the lysozyme done?
Lysozyme was not done.
Okay.
Also, and let's put lymphoma in there too. So.
Okay. So here's a sample, here's a H&E slide of the sample, of the biopsy sample at 40x magnification. So far we see chronic inflammation, as well as this unusual appearing organism, which was read by our ocular pathologist, with these symmetrical, mouse come up, with these symmetrical spikes on the side of its body, kind of pointing towards its posterior end. And you could see some internal organization within the structure, within the organism. And just for size comparison, this is a neutrophil here. So you can see the organism, or this organism is about 3 to 4 times the size of a neutrophil. So our ocular pathologist discussed the case with several of his colleagues, and he was unable to really make a diagnosis. So we sent the slides to the New York State Microbiology Laboratory, as well as to the CDC, to see if they could help us in identifying.
So there was just one of these in the lesion?
Yeah.
One.
Mm-hmm. So at this point, I'd like to also open up for discussion.
Well, you got our discussion. Keep going. You got 2.5 minutes to educate us.
All right. So we did think this was something in the infectious family, infectious etiology. We thought about toxocariasis, but her serum toxocara antibody was negative, and that's a pretty sensitive test. We did send for toxoplasma, and she did test positive for the IgG, but that test has not a great specificity at 42.3%. Other things we were thinking about in the parasite family, cysticercosis, but this didn't have the classic retinal or subretinal cyst that you see with that. One thing we also thought about is it could be processing artifact. It's possible that the vitrector cut up the organism, and by the time it was examined at the microscope, it was kind of unrecognizable. So just for comparison's sake, we didn't think it was bacterial in etiology. These are some bacteria here next to a neutrophil. You could see they're much smaller, on the order of 1 to 2 microns. We thought it was more in the parasite family. Here's a toxocara egg. It's about 50 microns here, and different helminthic eggs ranging from 30 to 100, 150 microns. So that was in the same size range of our organism. We got an official response from the CDC, and they said they were unable to identify the organism as well. I reached out to the editor of the journal Parasitology, also unable to identify. So the biopsy did trigger some intraocular inflammation. She had vitreous haze, 3+ vitreous cell. Her vision dropped to 2400, and we still didn't know the organism that was causing this granuloma, we're calling it. She was on Pred Forte Q2 hours. You can see the vitreous haze there, a hemorrhage in the area of the biopsy, as well as the lesion. She developed subretinal fluid. OCT through the lesion, B scan at post-op week 1. You could see some just Pred Forte post-operatively.
Was she empirically started on any anti-helminthics?
That was discussed. We didn't start on any anti-helminthics. We weren't sure exactly what we were treating. And
You did it along with steroids.
Yeah, I mean, you're losing an eye,
Exactly.
and the side effects are worth taking a chance. I mean, it looks like you should be able to go after this.
There's a post-op month 1 fundus photo showing exudating the fovea. Vision is now down to finger counting. There's OCT showing subretinal fluid and hyperreflectivities in the outer retinal layers. There's the FA.
I'm hoping this story will. Oops.
So you have the patient on big doses of steroids, I presume?
Uh-huh.
Yeah.
Yeah, her vision did improve to 20/60 at post-op month 3, and the exudates were clearing a bit, but she still did have some subretinal fluid. We referred her to see an infectious disease doctor to see if they had any other input in terms of managing this.
How much of this did you take out? I mean, what made you think you were treating it? I guess what I'm saying is you found a parasite, probably some sort of nematode. The treatments are pretty non-specific, and you chose not to do that. Is that because you thought you had excised everything?
No, it wasn't that. There have been, during our discussion, there have been some previous thoughts that it could unleash some inflammation if we were to treat with anti-helminthics. But
The one comment, couple of comments I want to make is with surgery, you probably unleashed whatever was going to be unleashed.
Yeah.
So at that point in empiric therapy, I agree with Dr. Barker that the risks and benefits are pretty obvious. The second point I want to make is this is always difficult, right? You see a huge lesion in the eye, but the patient is 20-25, and we gave her a vision loss by our procedure, and we are all at some point in our lives guilty of the same. So at this point, her vision is down, and second sampling is very low risk. In my opinion, you could do that for PCR purposes. That could potentially give you the organism. Or you could go empiric and do a wide spectrum or a non-specific aggressive anti-helminthic therapy along with steroids to control the inflammation. And you won't know what you're treating, but if she got better, it would still be good. And the other thing I wanted to say is that toxocara, peripheral blood negativity, has been seen in up to 30% of ocular toxocara. So with a peripheral titer, you cannot rule out an ocular toxocara.
okay. Thank you.
Okay, thank you.